Thank you. Good morning, everybody. These are my disclosures, so a few more than Jay's, mostly with Siemens. We find ourselves in a difficult place when we think about imaging of patients with metastatic disease. Many of you will use bone scans and CT scans to detect metastatic disease and to assess its response. And I'm here to show you that this is something you should not be doing in the way that you're doing it, and I think you should be thinking about moving forwards. Because oftentimes when we think patients have no disease, they have disease. When we think we've got small amounts of disease, they have a lot of disease. And that stems directly from the technologies that you are using. We're also beginning to realize that in this era of precision medicine, that the heterogeneity of response is increasingly important for patients' prognosis. And current tools don't cut it for that particular role. And finally, we can't detect patients' responses at a point when patients will benefit from a treatment change. We wait too long before we change treatments. And I just thought I'd illustrate what you are doing today and why it is wrong and bad for patients. So here's a patient with prostate cancer, castrate resistant, so towards the end of the journey. In the clinic, they would use PSA and they would use bone scans and CT scans to assess response. So first exam on the left, the PSA is high. You can see this is a whole-body MRI scan. I'm not going to talk about that straight away, but this is part of a whole-body MRI scan. Here is the bone scan. So the bone scan is negative because there's no bone disease. That's fine. The patient starts on a very expensive treatment called enzalutamide, which is an AR blocker. You can see that the PSA goes down, so your clinician's extremely happy that things seem to be working. The bone scan on the follow-up you see is still negative because there's no bone metastases, and you can see a response here in the retroperitoneal lymph node. So everybody's feeling great. Sorry, just go back. At week 13, week 25, again, the PSA is suppressed, okay? So the clinician's going to continue his treatment. The bone scan is negative, but on whole-body MRI scan, we see a dot. Now, some of you will look at that dot. I can't see that dot, okay? The advantage of the whole-body MRI scan is, of course, you've got 2 prior studies, and of course, it's possible to focus down on that lesion. And you know that's a new lesion. So this is oligoprogressive disease. Alarm bells should be going at this stage. But are they in the clinic? The answer is no. Because the PSA is suppressed, the bone scan is still negative. Okay? So another 12 weeks goes by, and so I'm ringing this alarm bell. My clinician says, actually, it looks fine. I'm going to carry on. Okay? Another 12 weeks goes by, the PSA is still suppressed. Okay? Now there are 2 bone lesions. The MRI is showing 5 bone lesions. Is this progression in the clinic? The answer is no, because progression needs to be confirmed. So what happens? Another 12 weeks go by. Week 49. Now the bone scan shows metastatic disease. The whole body MRI scan shows bone disease. So what's happened? Week 25 is when progression actually occurred. Week 50 is when you change the treatment. 25 weeks of treatment that was of no benefit. Thousands of euros. Thousands. An order of magnitude increase in tumor volume while everybody was doing this, right? This is what's happening in the clinic. And this is a real issue in the clinic because we do patients a disadvantage because of the crappy techniques that we use in the clinic. Now, so the MET-RADS system was formed to address some of these issues and was published earlier this year with some of the people that are in this room, including Heinz-Peter Schlemmer, who's sitting at the front. And what we wanted to do was to place whole body MRI scan at the front and center of this technology. And so what we decided was to establish minimal criteria for assessing disease. So we decided to design a protocol that will be suitable for detection, which consists of 4 sequences through the whole body. So the core protocol consists of a spine T1, a spine stir, an axial T1, and a diffusion sequence. Now that's not tough, okay? That's all you need to do, whole body, half an hour, depending on your system. If you want to do response assessment, then we push you a little bit more, and what we do is an axial T2 of the whole body, so you know where bits are in the body, and then you may want to do some regional assessments if you see, for example, you may want to focus on the brain or the prostate or on the liver, depending on what you see. You may want to give contrast. So that could take a little bit longer. So essentially, this is what a core protocol looks like. A spinal T1, T2, a diffusion of the whole body, make a MIP sequence, and this has been applied in this particular instance to somebody who has multiple myeloma with this typical salt and pepper appearance that all of us are familiar with. But the important thing for you to remember is that the axial T1 is a Dixon sequence, so that's really fast, okay? If you do it in the coronal plane, you can do the whole body in 2 millimeter cuts in under 2 minutes. Under 2 minutes for the whole body, from the top of the head to the mid-thighs. That's not tough, and you should be able to do that. The interesting thing is you can calculate a fat fraction. So on the bottom left, you can see this is the fat fraction, and this is the ADC. So you can see how we can combine anatomical and functional images to this protocol. If you want to do a little bit more, the comprehensive protocol, then it consists of a T2, which you see here, and a Dixon sequence in a different plane. So here's coronal, here's the axial, and you can then reconstruct the whole thing, and that's what it would look like at 3 Tesla. So the previous example is at 1.5, this is an example at 3 Tesla, and what you notice is that this patient has active disease, for example, here in the prostate gland with lymph nodes in the pelvic side wall. So this is a typical comprehensive protocol. And you can cut these images in different planes to be able to evaluate what the whole thing looks like, and this took 45 minutes. Okay, so if you have a modern system, you should be able to do something like this. Okay. Not only did we set up a protocol, but we gave you a reporting system, which is why you're in structured reporting this morning. Okay. And this is what the structured report looks like. It's a piece of paper that has 2 sides. Simple, right? And side 1 and side 2. And there's a diagram of a body to tell you where the bits of the body are. Not you, but your clinicians, right? And there's a reason why that diagram is there. And that's because when this version changes, something else goes into that space. Now, what we've had to do is to develop new criteria for response assessment in bone. So this is not like LIRADS or PIRADS where it's about detection. This is about response assessment as well. So this is a slightly broader remit. So we've taken RECIST criteria, the standard RECIST criteria, and the version that is applied to prostate cancer, called the Prostate Cancer Working Group 2 criteria, which you can see here, PGCW2, for the soft tissues, but we've had to develop criteria for the bones, because the bones are not within RECIST. Okay, and so we basically categorize response using morphological imaging and diffusion imaging into 5 categories. So, category 5, higher number, highly likely to be progressing. So that's 5. And you can see that soft tissue disease just uses standard RECIST criteria, whereas the bone disease converts pictures, which we're used to looking at, into words and categories. But you'll also notice that there is a diffusion criterion added on. So most of the evaluation is morphological with some diffusion. Let me just show you an example of something you will all recognize, which is a patient getting worse. Okay? So this patient is being treated with maximum androgen deprivation, MAB, or combined androgen blockade, and the patient's getting worse. And it's obvious, yes? On the T1s and the STIRs, we all recognize this patient is worse. Here, on the diffusion sequence, you can see more black bits. This patient is getting worse. So this is an obvious case of disease progression. Now, it's possible to segment the data and actually say how much cancer there is. Okay? So on the left, 43 cc's of cancer. On the right, 470 cc's of cancer. Or for your clinicians, they like red, green, and yellow. So you can color this stuff in and say, you know, there's more red here. Your treatment isn't working, right? And you know, it's interesting how I get WhatsApp messages saying, can you send me those color maps, please, from my clinicians. So it's a way of selling this to your clinicians, if you like. And you can see that the ADC does not change. The ADC does not change. Okay, so here is exam 1. There's the median value. Here's exam 2. More tumor. ADC does not change. Okay. Now, so that's what a MET-RADS report looks like. So a few pictures, a text report, and the MET-RADS picture filled in by hand. Okay, so you can see on the left we have all the soft tissues. On the right we have bones. Is there involvement? Yes or no? Simple, per region. And then within region, what is the dominant response and what is the next dominant response? Okay, so what's the most common response and what's the next most common response? So it's like a Gleason score, if you like, the most common Gleason score and the next score, but on a region by region basis, dividing into soft tissues and bones. Takes about 2 to 3 minutes to do this. Okay. Similarly, we've had to develop criteria for response. Again, we were able to take pictures and convert those into criteria, and interestingly this time, we have included ADC changes. So the delta ADC, the change in the ADC value, is now emphasized as a new criterion for response assessment in bones. So category 1 and 2, highly likely to be responding and likely to be responding. 3 is stable, 4 is likely to be progressing, 5 is highly likely to be progressing. So again, using that Likert scoring system. But importantly, you'll see that what we've got are morphological criteria, but in addition, we have diffusion criteria, looking at the change in ADC, the delta change in ADC. So if you guys were going to look at this patient's been treated with chemotherapy, the patient has prostate cancer. If you looked at the morphological sequences, you would call this stable, right? So every day in the clinic, you would look at those images and say, this patient is stable. If you were to do diffusion imaging, a policeman could say that this patient is better, right? Because you can see there is less black on the MIPT diffusion sequence. And if you were to look at the ADC values, you can see that the ADC increased. So this is the histogram before treatment, examination number 1. Here's the ADC histogram for examination number 2. And the ADC has clearly increased. So the morphological criteria are stable, and that's what you would report. If you use the diffusion criteria, it says this patient is responding, carry on. Now, it's possible then to project these colors onto the image, which is not part of the MET-RADS system, but it gives a view of the whole body saying, where is the active cancer? Okay, so I will often show clinicians those 2 images on the left, because they know that the bits that are still alive, the red bits in the lower lumbar spine and in the left proximal femur. So this is heterogeneity of response. Remember we were talking about heterogeneity of response? Why it's important? This shows you why it's important. Because this response isn't complete. You need to carry on the treatment. So again, this is what the report would look like. A couple of pictures, a text report, and you would fill in what the responses are in the different regions with any comments that you might have in the center. Again, takes 2 or 3 minutes to do. One of the most important things that we wanted to capture was this issue of discordant responses. In other words, where some bits get better and some bits get worse. And how do you capture that and make it very real for clinicians? So let me show you another example of a patient with prostate cancer. Now, if you were to look at this particular patient, being treated with Radium-223, so a type of radiotherapy, a liquid radiotherapy if you like, you can see that the patient is clinically worse, right? Symptoms are worse. He's becoming transfusion dependent. His albumin is falling. But his PSA has gone down. So biochemically, he's getting better. Physically, he's getting worse. So the clinician's scratching his head, thinking, hang on a minute, what should I be doing next? Is he getting better or is he getting worse? And this is a common scenario. Believe it or not, it's something like 20 to 30% of patients with castrate-resistant prostate cancer get this. That's 1 out of every 3. This is when they'll come to you. Okay. So, if you were to look at the spine, morphologically, which is what you would do in the clinic today, you would say this patient is worse. And you know what? You'd be wrong. Again. Right? Now, so do the diffusion imaging and you'll see there are new retroperitoneal lymph nodes. So here we go. There's single node, multiple new nodes. So the nodes are getting worse. Okay. What about the bones? Well, let's just divide the thorax and the thoracic spine and lumbar spine. Just consider them separately. Okay. Let's look at the diffusion imaging in the dorsal spine. If we look in the dorsal spine, here's the ADC before, and here's the ADC after. The ADC has increased. That's a response. Interesting. What about the lumbar spine? Well, if we look at the lumbar spine, here's the lumbar spine in the sagittal plane, in the coronal plane. So low B-value signal, low ADC, and then the signal increases. That's not good. And then you look over here, the ADC is down. This is new cancer. So you're saying the dorsal spine is better, the lumbar spine is worse, and what about the legs? The legs are better. Look at the ADC. So this is that 1 in every 3 to 4 patients that you see in the clinic, except you don't see it today. Right? You're not seeing this. This stuff is happening, but we're not seeing it. And that's why we should be using a technology like whole-body-MRI. So we can then conclude and say the dorsal spine looks worse morphologically, but is actually better, and that's called T1 pseudo-progression, which is well recognized in the literature. There is actually true progression in the lumbar spine, so discordant response. Now, you can see that we've got discordant responses in nodes and in the bone, and different parts of the bone are doing different things. And this is really, really important because that alters a patient's prognosis. I mean, it profoundly affects a patient's prognosis. And that will come out in the precision medicine session, which will be after this break. And then you can represent this, if you like, in a color map, as you can see there, and you can say that you can show that sort of color map and then give some idea on how much tumor is alive before and how much tumor is alive afterwards. So we can say, I haven't written it down. But anyway, you can represent this type of imaging. So the MET-RADS report would look a bit like this, and then you would write your notes here. You'd say progression in the nodes, response or pseudo-progression in the dorsal spine, but true progression in the lumbar spine. So it's a way of recording and communicating discordant response to your clinicians because they want to know this. And it's very, very important. Now, the important thing is, so we've looked at spatially discordant responses. Now it's possible to codify this, and this is not part of the MET-RADS system, but it's possible to codify this and develop what's called a heterogeneity index. Heterogeneity index just from those numbers. And that can be done with an Excel spreadsheet fairly quickly. But this is where the spatial heterogeneity really matters, and I just wanted to emphasize this. So we've used this spatial heterogeneity index in breast cancer receiving hormonal therapy. Every one of you has hundreds of patients like this. Hundreds of patients. Using this technology, if you see every bit of the bone, every bit of the tumor behaving exactly the same, that patient will continue on treatment for a long time. So in our group, it was 24 months. If you see some bits getting better and some bits getting worse and some bits staying the same, that is bad for the patient. So all of us will say, yeah, this bit looks okay, but this bit is better, and we think that's okay. Actually, those patients do worse. Those patients do worse. So when we say to our clinicians, you know, everything looks stable, but this bit here is better, that is a bad sign. We smile, bad sign, right? And the data proves it. And the data proves it. So let me just show you an example. Here is a patient who is completely stable. Completely stable. So first exam, second exam, 4 months later, nothing changes. So when you say this is stable, this patient's going to stay stable, half of them, for over 2 years, right? This patient has a classical discordant response. You can see the breast gets better, this metastasis gets better, this rib metastasis gets better. Okay, good news. But this one gets a bit worse. So here we go. Look, there it is on the diffusion sequence, gets bigger. And there are other bits that are stable. So that stays stable, that stays stable. Okay, so you'll say, well, majority of it is either better or stable. And you smile. Bad, bad, bad. Bad. Why bad? Because one lesion got worse. The heterogeneity index increased in this particular, so you have a discordant response. Different things doing different things to a particular intervention indicates that this is an aggressive cancer. And this patient went off treatment in 9 months. So discordant responses are important for your clinicians in breast cancer, in prostate cancer. Okay, so this is my last slide. The MET-RADS system was developed to codify response to treatment, to meet particular clinical needs in terms of assessing response, focusing on soft tissues and bones. So this is not about detection, it's about response assessment. So it's slightly different to the other two talks. We have tried to standardize this sequence so it can all be done within a half an hour to 40 minutes for a CRO protocol, and for a comprehensive protocol, it's about 10 to 15 minutes later, depending on what you decide to do. But the whole thing can be done within an hour. So if you're spending an hour doing the prostate in an organ this big, you can spend an hour doing the whole body. Okay. We've had to develop new criteria. You've seen those. These criteria summarize the likelihood of response. We've tried to capture spatially the discordant responses because those are important. Clearly, this is a new system. It was only published in March this year. It requires validation. So we would encourage you to go away and start using the system, and then coming back to us and saying, this works, this doesn't work, there are issues, I don't understand this versus that. But please use this technology and come back to us, and then we'll think about the new system and how we modify that. Thank you very much indeed.